Happy Friday,
Hello,
everyone.
happy Friday, Jamil.
Yes, my name is
Amazing
Jamil
audience.
Rivers. I am the founder and CEO of the Chrysalis Initiative, and we were invited by the awesome Alamo Breast Cancer Foundation in order to speak today on disparities for the Advocate Program during SABCS. I am actually a proud advocate and Alamo program alum, so I'm so happy that we get to talk
But
about this issue. And I couldn't think of who else would I like to do this program with than Maimah Karmo, who is the founder and CEO of Tigerlily Foundation. We are both engaged in this work every day, and I think it's really important for us to move this conversation forward. And it's really the advocates that we lean on in order to make sure that this work is able to make the impact that it does. So, Mamie, would you like to say a few words and introduce
I would
yourself?
love to say more than a few words. So, everyone, thanks for being here. Thanks for watching. Alamo, thanks for having us be part of this program. I'm just so blessed and honored. Well, blessed to be alive for 15 years post TMBC diagnosis, for which many of you know until last year was no targeted treatment for triple negative. So, I believe every day I'm alive is a day to serve God and my patients and my friends through this work. Um, I began Tiger Lily when I was in treatment. After facing many of the barriers I work to end today. Even though I knew my body enough to go and ask for for a screening, I was too young and they didn't want to cover me with insurance. My physician dismissed me. My diagnosis was delayed rather. And so when you talk about disparities, I am so thankful that I am one of those who survived. But I think that the privilege we have now is with our breath in life is to now ensure other people have the same level of equity to have better treatment, access, delivery, outcomes, and as well. So I'm proud to be here to have this discussion with Jamil today and our other guests who will be joining us shortly.
Yes. So speaking of which, I would like to introduce our moderator, Ashley Dedmon, and also our additional panelist, Dr. Andrea Phillips.
Happy Friday, Maimah. Happy
Happy
Friday.
Friday, beautiful.
Hi, Ashley.
How
Hi,
are you
Dr.
Hi,
doing?
Phillips.
Ashley.
Hi,
Dr.
Dr.
Phillips,
Phillips.
great to have. Look at this nice brown chocolate panel right here. I love this.
Right, Black Girl Magic. All right.
Girl magic.
So
So
thank you so much for agreeing to join the panel and also agreeing to moderate. Ashley, would you like to introduce yourself?
Absolutely. Thank you, Jamil. Thank you. Happy Friday again, everyone. My name is Ashley Dedmon. I am a proud Tiger Lily NBC Angel Advocate. And I had the opportunity to speak on the disparities in clinical trials at SABCS earlier this week, where it was just so empowering for all the advocates and all the scientists and doctors just to come together and have a much needed conversation. And I think we have to get uncomfortable we have to get comfortable with getting uncomfortable and having those conversations. So I'm super excited to be here today, where we will be discussing disparities in breast cancer care and that forward thinking action for 2022. So I'm going to kick it off.
Oh, well,
Oh,
really quickly, Dr. Phillips, would you like to
I'm
introduce?
sorry.
yes,
Hello. Thank you so much. I am so privileged to be among this group today. This Black Girl Magic, powerful Black women doing lots and lots for our communities, our neighbors, our friends, our sisters. And I have a background in family medicine, and now I'm a clinical trialist. I've been doing clinical trials for over 25 years, and to see the disparities there, along with in the treatment areas. Um, Caused me to make a real commitment to this area, to addressing this. So I'm so privileged to be a part of this panel today. Thank you.
thank you
Awesome.
for being here. You are so amazing. For those of you, Dr. Phillips, who don't know her, she's very she's understating herself. She has been in doing clinical trials for over 30 plus years and is one of the foremost community providers that's had success getting Black and Brown people in trials. And so we have her on to be able to learn from her what she's been doing, what are her best practices, but also to have the fortitude to stay in this work for all that time when people weren't giving the support and were on the ground. I just want to honor you for being who you are because you people like you are why many of us are alive today. So I want to have just take a moment to honor that what you do.
Thank
It's
you so
so
much.
needed. Okay.
And I think it's really important to highlight that it's usually the family physicians and the primary care providers that are the first, person that people are going to in order to get that breast cancer diagnosis. So it's really important for us to highlight that. And I wanted to invite this meeting of the minds because of the fact that we are engaged in this work as advocates, as leaders, and we know what is still needed as far as those gaps and solutions. So thinking about 2022, what is it that we need to do in order to really address these barriers to equity? So Ashley, kick it off.
There we go. So to get us started, here is a provocative quote from an unattributed source that I know our panelists are familiar with. Here it is. Doctors are to Black women what police are to Black men. Now, this is a powerful statement. So, Maimah, I'm going to kick it off with you. Can you explain it in terms of disparities that exist in our healthcare system?
Well, I think when you think about police, you think about, for me, I think when I see a police car, I get nervous. I never feel safe. Okay, because to a Black person, that means you're in trouble most of the time, right? I wish that were not the case, but I myself have been experienced great harm at the hands of the our police force. Just not great harm enough, meaning psychological harm and trust harm. And so, and a lot of I have four brothers who are Black and brown, and a daughter who is biracial, but she presents as Black. This things happen to her. So that level of this is a body that you're supposed to have trust in, that they'll protect you, and they don't always do that, right? And so I think police are to Black people what healthcare providers can be in the healthcare system. I shared recently with Jamil and other people how even as soon recently as May, where I have anaphylactic health issues, and I had an attack, and my daughter who's 18 took me to the emergency room, and literally after I came out to myself after getting two EpiPens in less than half an hour, it was that bad. The first thing the attending physician asked me was I using drugs or alcohol? And I literally I was weak, but I was so hurt and shocked. I started crying. And my daughter said, "You should tell him what you do for a living. Tell him who you are." And I said, "I really appreciate it, honey, but you shouldn't matter who I am, what I do for a living, where I live, and what my skin color is. Because people who have less die at doctors' hands like this all the time." And so, um, not to go on, but the work that we're doing is that, if people don't trust physicians who's meant to protect them by that Hippocratic oath, who can they go to trust that will take care of them in the healthcare system so they won't dismiss them? Like my friend Shantae, who Shantae I got dismissed for 6 months. She got dismissed for 6 years. She's now metastatic. So this disparity with the physicians who you're meant to trust is a huge one that I work to fix every day through training, advocates like yourself and Jamil, who now has Chrysalis, and she also works with healthcare systems. And Dr. Phillips works with patients in the community. So that uniform, whether it's Black or brown, can be for us a detriment, and it should not be that way.
Maimah, you gave me chills. You're right. Sometimes we have to go in and almost have to explain who we are and almost go off our credentials and what we've done. And you're right, we shouldn't have to do that. It's just the simple fact that I'm a woman, I'm a Black woman, I need care. That should be enough. And it's not. And so,
or a human being. I'm a human
being. Exactly. Jamil, I'm going to pass it to you. I would love to hear your intake on this powerful quote.
Yeah, I think it goes to speak to when we look at the maternal health disparities, right? Where just being believed, having that patient-clinician communication and that connection is just, with Maimah's example, that bias could actually influence the care that she potentially receives in the setting. And what happens is it's a cumulative effect. I think we have this convenient narrative that, disparities, if we just deal with poverty and access to care and insurance, we're all good, right? But we know that it's going to take more than that because, again, Maimah is a perfect example, wasn't an issue of access to care, wasn't an issue of income or lack of education or insurance, but time and time again, and especially with the work that we do with the Chrysalis Initiative within the health systems, we're able to show how bias creeps in, right? And it's actually able to inform the impact to patients. And it's not, we all have our biases, that's fine. However, when that bias and racism impacts the care that a patient receives and those holes and gaps, it ends up resulting in a cumulative effect where just that delay to get the mammogram, to get the appointment, as that breast cancer is now progressively getting worse, the impact on that, and so that delay can cause, that disparity can be at diagnosis. Or what about when we have an example of one of our participants, Kim, who didn't receive the full diagnostic scope of testing that she was supposed to receive. So treated 4 years for breast cancer, metastatic breast cancer, diagnosed at de novo. And come to find out, it's not just ER positive and PR positive, but HER2 positive as well. So now this HER2 positive aspect of her breast cancer has had the opportunity to become progressive and aggressive worse and constantly progressing over and over again because of the fact that she didn't receive that sufficient testing, right? And not an income issue, not a lack of insurance, but just that depraved neglect, I kind of call it, where it's just those gaps and holes that creep in. And I understand that there are errors, but this disproportionately impacts Black people in the care setting. And so I think it's important as advocates for us to know going in that it's not just dealing with access to care. It's not just dealing with barriers and insurance and income and education, but making sure that bias and the structures within the care setting, that there's that accountability as well, so that these, types of issues don't happen. And when we address that, it equalizes the outcomes. We no longer have those type of disparities. And so that's important.
And Jamil, it's important to your point to be aware that there is bias, and this may sound odd, but some people don't know they have it because they're born in it. They're born.
They
I've
think,
had-
oh, well,
they think nothing
that's
else.
racist.
No, I didn't do anything wrong. Like I had somebody, a white woman, older white woman, reach out to me during more than one actually, but one less struck me because she was older, probably in her 70s, I think, and she said, we were talking. She said, I had no idea that I was born to a racist household, and I was taught these behaviors and these ways of thinking all my life. And she just was learning after the murder of George Floyd that she may have thought I was an amazing person, but she had biases, and she works in breast cancer. And so she said she had to unlearn this stuff, and she was in tears, unlearning this and realizing her privilege and what things she made assumptions about. So it's not that people are all inherently bad, but they have to be checked, and they have to be made accountable, because unless they're made accountable, and and it's hard, right? Because you're like, I'm a good person, they think, but they don't know their racism impacts our healthcare and our life and quality of life. So if we're not checking that, doing what you do, equity assessments, or having Tigerlily go in there and doing these pull up a seats, whatever, they don't know. And what hurts me with Shantae's story is, like, for me, it was 6 months delay. With her, it was 6 years. She went to her doctor with multiple issues. She's a nurse, by the way, so she knows the healthcare system. And she was dismissed, and she even had until she had bleeding nipples. And then she was taken seriously. And so I always discuss her because her story is only one of millions of stories. It's not the only story. So unless the provider is educated about their innate bias and or overt racism, unless the healthcare system is made to check themselves and be disincentivize or get whatever for doing the right thing. If they lose their certification, their credit, whatever, how do we keep them accountable, whether it's with their pockets or their certifications? Because if we don't do that, we're going to always be at their mercy, and we'll have more Black women dying of breast cancer at that 40% higher death rate, which is unacceptable.
Exactly.
This is oh, I'm sorry. I was about to speak up anyway. But this is such a powerful statement. That doctors are the Black women, what police officers are the Black men, and to Maimah's and Jamil's points about the bias, it is just a double whammy, really. We look to our law enforcement to protect and serve. And it's the same in the healthcare system. We look to doctors to protect us from a disease, to prevent things, and then to serve us, to meet us where we are, and to listen to us and diagnose and treat. However, Black women have a double whammy, and it's unfortunate. It's racial, but it's also sexist. I tell you, we have trouble with men listening to women in general in the healthcare system. So you have a Black woman who comes in with certain symptoms, or even just for screening, and her symptoms are not taken as seriously. So in my role, as now often the person who is speaking to other physicians, to other healthcare providers, I am saying, listen to women when they come in, listen to Black women. They live in those bodies, and so they know their bodies. And I'm saying to patients, trust you, what you're feeling, and make a point of it to say, I'm not going to leave here until I know you hear me.
Right.
And whatever that takes. And sometimes you may be labeled an angry Black woman, but that's all right too. And it doesn't have to come out in anger, really, but if necessary, do it, because I am the more that I've been in healthcare, the more that I have learned to listen to patients, and the more that I have my own personal health experiences. We live in these bodies. We can generally tell when something is not right, even if that initial screening says one thing or another. I'm not talking about people who are hypochondriacs, people who are overly anxious. I'm talking about your average woman kind of knows her body. So if you are convinced, this is my message to patients. If you are convinced that there is something wrong that's going beyond what the doctor is saying, just take the time, schedule another appointment if necessary, to say, we just need to talk and you need to hear me, and go a little further with this investigation into, my symptoms. The other thing that I'm telling healthcare providers is, because this is what's worked for me, you know, I had a teacher in medical school. He was a really old guy. He was like 80 when I was a first year medical student. He said, if you talk to the patient long enough, they'll tell you what's wrong. And that makes diagnosing easy. You have to talk to a patient long enough and listen. They will tell you what's wrong. And I'm telling you, that holds true 35 years later. If I listen to a patient long enough, I can get to the bottom of what's going on, even without the exam and all these tests, about 80% of the time. So, my message to women everywhere who may be listening, just don't give up. And if you really, after trying several times to get one person to listen to you, they can't hear you, you need to go to someone else.
Also, you know what? Sometimes it's difficult for those patients to be assertive, or
Right.
to, we have some rural areas where the next hospital is quite a distance, or, sometimes they have policies within these health systems knowing that there aren't these resources, and they'll say, well, if you don't like this doctor, then you need to, step on out the door, because you can't change doctors within the health system. And it's crazy that this happens, but this does. And so I would just implore those folks, where get the support from the Chrysalis Initiative and Tigerlily Foundation, where if you can't assert that yourself, at least have the backing. Because I can tell you, when these patients have the backing of our organizations behind them, and we're be able, even if you don't say it, just print out the paperwork and take it with you to your appointment, right?
Yeah. Yeah.
And then we help you get that second opinion, and then they see, oh, uh, she knows what she's talking about. She knows what tests and what she's supposed to be receiving as part of standard of care. It's a little harder to push back on you. And so, even if
Mhm.
you don't feel equipped in order to advocate for yourself, there's so much support out there for, organizations to help you, that you can tap into and get that support in order to make sure you get the care that you're supposed to get.
But
That's
there are
a
two
great.
things, Jamil. Most people, most women and people in general aren't taught to question doctors.
Mm-hmm.
Because
Yeah.
I grew up with a mom who's a nurse and people who were, I knew I could question because there were people. I saw them at home in pajamas. Saw my uncle in, whatever, doing tennis, having drink. I knew how. I'm like, I can access a doctor. But
Mm-hmm.
the average person's taught, here is me as a person. Here is a doctor. Then the scientist slash researcher, and then it goes like that, in government and so forth. So, one of the things, when a doctor misdiagnosed me and what she told me, it wasn't a lump, it was to come back in 6 months to a year, or better yet, when I was in my 40s. I just said, well, okay, can we try to aspirate the lump? It wasn't aspirating. So it makes very, if I only had one cell on my brain,
Mm.
right? If a lump isn't aspirating, it's not a cyst. So I'm like, okay, so I can question doctor. And I begin to question. That's how
Mhm.
Type even started, was me saying, what about this? If this doesn't add up, what about that? And just questioning quote unquote authority. Then I realized, as my friend Julia always says, Julia Mawa, she says, the patient was really the expert living with the cancer disease, right? And the provider's job is to treat that body. So the expert really is a patient, but also they're expert at treating. So if we're coming together as partners, as co-pilots, that's when the magic really, really happens. You have to all be able to come together and know that it's not this hierarchy. We have to be able to trust and to work together. I
And
think
that is so true, so true. Because
Well,
most of the women that we connect to, they're not aware that they are dealing with bias or impacted by
they have
bias.
no idea.
And
But look at
right.
look at
Because it's
social
not
media.
overt, it's not obvious. It's
But
just
look at marketing. How can if you put on your Instagram right now, Instagram or TikTok, whatever, when you see Black women, they're hypersexualized. They're promoted to things in a way where we're not getting messages that are health focused or that are holistic. The communities that have disparities, you can't find a Whole Foods or healthy places to have to even garden. So
Mhm.
if you're being told that this is not important to your community and you don't see it represented on advertisements in the marketing, then you won't think it matters. Whereas people who are not of color have so much content for those people, but we're the ones having the highest death rate. So to me, I always ask companies, as part of their inclusion pledge commitment, whether you're doing marketing for clothing, marketing for healthcare, for whatever, let the Black woman see herself represented in what you're doing, to know that it matters to her and to her life. To be honest.
I agree so wholeheartedly, and you both make such a great case for the types of organizations you represent and have established, because you're so right, Jamil, when you say a lot of women don't feel empowered enough to even question or to suggest, maybe take a second look. So what I've done is say, take a family member, or you know, lots of times I had to do one of these calls this morning. I had to make a call to a specialist. It was not in the cancer arena, but in the cardiology arena, because they'd scheduled a patient of mine for a procedure on Monday, and I saw her yesterday as a patient, and she was like, "I don't know why they're doing this, and I don't know. They just told me I have to come and do it, and I just don't feel comfortable about it. They're about to do an implant an ICD." And I'm like, well, the last report didn't indicate that you were at that point yet. Anyway, my point was, I called her physician, her cardiologist, and again, I'm the redheaded stepchild in medicine now. I'm family medicine. They think we just are gatekeepers and that's all. But no, the patients will always come to us. So I called and said, so I didn't get him yesterday, didn't get him this morning. So I just called and told his office the procedure is going to be canceled until I understand why she needs it and she understands why she needs it and feels comfortable. So sometimes we can find advocates in different places in our families, sometimes in the clergy. Go to your pastor. I tell people, utilize whomever you need to help you walk through this. But these organizations that you guys have, I mean, that is so key to what patients need, especially Black women who, like I said, have the double whammy. They're women and women of color. And so men aren't listening and white people aren't listening. So, just need whatever support they can have when they go into these places and have to, literally demand, proper treatment.
I know the fact that we have to ask for the biopsy, you
Yeah,
know, just,
it's ridiculous.
Yeah.
It's
you
And
just
know,
ridiculous.
Dr. Phillips, I wanted to ask you too. You've been doing this for a long time, right? And for people like for us, three of us who are patients, excuse me, we've seen so much focus on health equity and gotten more opportunities that there weren't there before. Up until 2 years ago, my revenue and the respect. I mean, the revenue, we were able to do the work, right? I couldn't do what I wanted to do because we weren't getting adequate financial support from organizations, or weren't getting the right credit, because we were on the ground. People were calling, and it. Trust me, I know it's hard, because I funded my org myself 95% for almost 13 years. Almost,
Hmm.
it's fully just fundraisers, myself paying for it, a small funding here and there. And so I just want to go back to you, because the work that you've done for 30 years is not easy. As a woman, as a Black woman in the healthcare system, to be able to get patients that come to you for trust that you're seeing in mass amounts and you're spending time with. Because I know that you guys sometimes oftentimes like penalize for the time you spend with the patient. So I just want to know how you did that for 30 years, because that cannot be understated. I had
Yeah,
15. I was like, I'm almost done. I'm tired, but I'm never going to go away. But how did you manage to survive and thrive in keeping you in this space?
you know, it's not easy, and you get encouragement from wherever you can, but I just have to say it was just difficult. I for the first half of my career, I practiced in other settings and was never free to do what I needed to do for my patients. There was someone, if it was a government clinic where, we saw a lot of the indigent patients that I wanted to see, patients who were not self-insured and that type of thing, but they were like factories, you just run them through and I was like, no, I want to take time. And then, but I learned a lot from those situations. Then I went the other extreme to a really private, exclusive kind of practice. And it was just the most miserable year of my career because I was not seeing the patients that I want to serve. And they were just, and it was all about money. So I even went to a little Christian health center who was, committed to the same type of patients that I wanted to see, but they were practicing like a charity, and I knew that wasn't going to last. So I opened my own practice, and it was very difficult, to do. But what I did was to try to walk a fine line. I tell people all the time, my practice is really a ministry. I was able to get into clinical trials in with the private pharmaceutical companies, the industry, and bring to the table what they really need, what the FDA was starting to demand, and that was African American patients, because they trusted me, because I was on the ground, going out into communities, literally into churches, Sunday school classes, these civic organizations, their meetings, having health fairs, participating in health fairs with any community organization to say, look, you deserve good health care. And part of the healthcare continuum is finding out which medicines work best in us for hypertension, diabetes, and those things that we, carry the greatest disease burden for. And because we were able to bring people into our office and treat them and then bring them into clinical trials, then the pharmaceutical industry pays well for that. That's just the truth. They pay well for that because they have to have it. And what we get in return is inclusion from the beginning of the medication development process to get medications that are suited to us, that work, so that when a drug rep would come into my office and say, a patient is hypertensive, you need to start them on a beta blocker, I would say, no, no, no. In this study, it showed that in African Americans, they respond better to a calcium channel blocker as the initial, or to a diuretic. And there would actually be enough participation of people of color in the study to justify that. And there has not been that from the beginning of my career. Most of the way we treat basic hypertension, diabetes was developed from the Framingham study, which was a whole group of white people in the Northeast in Connecticut. So I'm saying this was just an eye-opening experience for me, and one of the ways that we were able to gradually afford to do this, because we were not paying ourselves initially. So I understand that journey was to tie a traditionally money-making thing to what I call my ministry, which is serving patients, at the community level. And believe it or not, we have done that for so long and have been so consistent with it. Now the industry comes to us. If there is a trial and they need African American patients, they come to us. And often I'm doing the same trials that the universities are doing. And they're picking up the phone saying, Dr. Phillips, how are you getting these patients? We can't find them. It's like, because I'm right here in the community. I deliberately stayed in the urban setting, and Jackson is not much of an urban area, but I'm in the inner city area at community level. Literally across the street there are houses, and that makes such a difference. We're so accessible. They don't have to go to a building where they get to go to the fifth floor and some suite down. And that I think makes a difference. Staying in touch with other stakeholders in the community who serve the same people you serve, also doing joint ventures like that together, has made a difference and has brought encouragement at times that I wanted to give up. Because there have been those times, Mima. I'm not gonna lie about that. There have been those times where I see my colleagues moving on up, as they say, and I'm still here. But the other thing is there's a commitment that I have because I say, fortunately and unfortunately, I have been in the shoes of my patients so many times. I've been on the other side of the medical thing so many times where I was the one in the hospital. I was the one having to undergo treatment. And I think, God uses that to remind me and to show me and to educate me on what patients have to go through just to get some simple basic treatment sometimes. So I would just say to you young ladies, be encouraged. I know you will hit those times that you want to stop, but there's always somebody, and it can be me now that you know me. Just call me up and I'll encourage.
It's interesting for me, my daughter is like my biggest supporter because she was 3 when I was diagnosed and she saw me build this from like literally being in bed, bald, with the trash basket thrown up, needing help to go to the bathroom. Like I didn't respond well during my treatment. And then she would say, what are they doing? We're going to a fundraiser. What is that? I go to take her to cancer conferences. I take her all over the place, all over the country, all over the world with me. I have her little backpack and so whenever I would get tired, and I always told her that, this is my ministry, that God is, I made promise to God, I'm going to keep it. So whenever I do get tired, she would literally say, Mommy, it's okay. Just, you can just, I ran you a bath and she bring me some wine and be like, just take a nice bath with some bubbles. And then she will pray with me. And she
Oh,
says, tomorrow you'll start over again. And she says, people need you to not give up. And she says, and I'm like, it just touches me because the thing that we're all doing is that you're planting seeds of people that you don't even know you're planting seeds with. Like, I never know that she was watching me like that. That now she has the strength that when I get weary, she can push me forward. But also the patients are so incredible. Like the work that you're doing, Ashley, by sharing your voice with, your community is going to hear that work. Jamil's work that she's doing, it's like it's a ministry. So God's always like showing you signs when you think you're tired. He's like, no, 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 but look at that. Then you're like, what? Oh, okay, I can do this. You know what I mean?
yeah.
So people's lives depend on us showing up, right? And that's what I look at every day. I have a thing in my mirror. Is like people's lives depend on me, getting up and moving forward, no matter how I feel. There's so many people that fall through the cracks, as Jamil's always saying, because we even had a patient advocate who, in the past 6 months, we found out she didn't want to tell, but she was homeless, and she was like, we gave her some support, but we didn't know she was living in her car. And so, we had no idea. But so how could she get in? She didn't have a job. How could she get health care? So we had to figure out, and that's one thing I love that we do. I always wanted to be a one-stop shop. So if
Mhm.
any patient comes to me who's black or black, I mean anybody at all, any color, but if they're a person that's of color, particularly facing disparities, we're like, okay, tell me everything you're dealing with, mental health, financial health, travel, place to stay. We took care of all these things for her. Like, and she sent the most amazing email. She has a new job. She has a place to live. She's getting in back in treatment. Like, we literally came around her like a bunch of angels and advocated for her. And she's so uplifted now. So she has her strength to now empower her community members to be that voice they need, to ask early, to be persistent, to hire or fire accordingly, and to not stop till they have the right answers. And so it just, to me, because you said it's a ministry, right? And when you see life, your life as being a ministry, then you know that it's bigger than just you. But you have to always show up.
But I also think
The
it's
other thing,
intentional. I think it's intentional. So when I think about advocates, patients, health systems, hospitals, all the different roles that go into making sure that we can start addressing these disparities, in order to achieve equity, we have to be intentional. So I think it's great what we're doing with our organizations, where we provide that wraparound, where we understand what comprehensive quality standard of care is. Most cancer centers, insurance companies, the government, we all know what that quality standard of care is. And it's really just being intentional about making sure that we equalize the outcomes, and that we're making sure that that same average patient that typically is white, that is having that patient experience and goes in, and those resources are offered, and the full scope of testing is provided, just making sure that that is not compromised by bias. So meaning that for whatever reason, if a person has that influence and they can just, say, okay, well, I don't believe that this person, whether or not if it's due to bias or not, we don't really have to get into that. It's really just making sure that those barriers are addressed and that they get that same quality of care where it's not substandard care. We're on that continuum from diagnosis to treatment to survivorship to living with metastatic disease, that there aren't any holes or gaps there. And I think when we think about solutions and what to advocate for, we're not all going to have a Dr. Phillips, unfortunately.
Or Jamil or Maimah or Ashley, right?
Right.
Yeah, right.
But just thinking about those structural changes where it doesn't have to be few and far between, but the equity is the standard, so that we don't have these gaps internally within the system. And so it is pharma and the FDA making sure that they go to organizations and institutions and say, you know what, you can't just have a diverse population of Black and brown patients, but is it accessible? Is it inclusive? Are you making sure that you're providing the same level of care and attention and care coordination for those patients too? And I think if we just think about that with all of the different moving parts as advocates, all the different systems and touch points, that it is equitable and meeting the needs of patients, we can address these barriers and inequities.
I agree.
I'm sorry.
No, I was going to say I love everything that I'm hearing. I know from Dr. Phillips, first and foremost, thank you for your commitment. Thank you for not giving up, because it gives all of us that energy and that inspiration we need to keep going. I hear Jamil talking about the biases, implicit and explicit. And I know, Maimah, you referenced, we have to be willing to unlearn and relearn some things. And I know, Dr. Phillips, you said with what you said, you set up you set the table for that next question around clinical trials. So I wanted to ask this question to the panel. Can you, the lack of clinical trial participation by women of color clearly impacts clinical care. Can you share with us how this impacts and affects clinical trial research?
Yes, I've been doing this not so much in the oncology area, like I said, but for a really long time. And there's a twofold problem when it comes to clinical trials. One is that there's a terrible distrust of the healthcare system by people of color, and rightly so, because there have been some terrible things that have happened in the past. And what I found during my research and during my experiences, people don't necessarily know about the specific incident. Like, they don't know necessarily about the Tuskegee experiments or what happened with Henrietta Lack's cell line, but they just know from generationally, they've heard people say, well, I'm not going to be a guinea pig. I'm not going to let them experiment on me. I'm not going to do this. So it was really difficult from the beginning for me going out into the community. Well, starting with my patients. My patients trusted me because I take care of them, so I've been doing that ever since I got out of medical school. When I stepped over into research, it was a little easier to get my patients to join a trial, because they knew I would never do anything. My mantra in medicine is, if I'm treating a patient who is about my age or in my age range, I'm treating her like my sister. If she's older, I'm treating her like my brother, my mother, and then brothers, and like my child. Nothing less. I will never do for a patient anything less than I would do for myself and my family. And all my patients know this. So I try to teach this to students when they are with me too. If you can't do that, I don't think you need to be in medicine, because that life is just as important as your life and the lives of those you love. So they would trust me and become involved in trials. And then that word of mouth to their families and friends would spread. The difficult part was when I was going to speak to a civic organization or to a church or to a health fair group of people. But what I found was it's the same type of communication, just answering their questions honestly and openly, saying from the start, look, I know you don't trust this system. But I had to do this with doctors of color too. I'm the chairman of the board of our state NMA chapter, and I did a presentation about 5 or 6 years ago to the doctors in our state, the African American doctors. And I tell you, they had as much distrust as the patients did. They had as many questions as the patients did. And so I had to do that same kind of talk. It was really good for me. It was very eye-opening. But I said to them, and I hope it was eye-opening to them, you write prescriptions for these medicines every day for your patients. Why do you trust the pharmaceutical company to do it right for your patients? You write their prescriptions, but you won't become a part of the system that holds them accountable and make sure they include us in that development process. Because that's the way we're going to find out. Because we know, for instance, now that cancer is not one disease. Breast cancer is not one disease. Hypertension, diabetes, all of those have elements now, that especially when we're now getting into genetic makeup and precision medicine, we know there are nuances, and some go along with racial genetic makeup. Race is a social construct, I know, but that genetic makeup. So I was challenging, and so that's where I've gone now, is to challenging physicians, pharmaceutical companies. The doors have opened for me to address them directly. You can have a diversity coordinator or something in your company, but if it's just bringing in a set of people to do the same old thing, it's not working. Come to sites like ours, come to investigators like us who are successful, and learn from us. So fortunately, over the last 2 years, especially 3 or 4 years, I've had the opportunity to go in front of pharmaceutical companies at high levels and challenge them to develop mentorship programs, because the people that will reach diverse patients will be diverse investigators. So that means if you have to open your doors and help train some African Americans, some Hispanic investigators, do it. If you need to train more women, do it. Put some money in there. Then I've had the opportunity to talk to some legislative people about making sure we start to include this diversity training back in medical school levels. Because, I stumbled over into research, and that was fortunate. And I call it a stumble, but I think it was a divine thing that I got into this, because it has really opened my eyes to how we were treating patients without actually having the proof that this works well in us, So that's and I got off. I know I get off when I'm talking about everything, but
You need to get off. That's what we brought you here for.
No need to apologize.
so it has become, but like Jamil said, it has to be addressed on multiple levels. We were all the way down to the patient, supporting that patient in a way that they have what they need to go in and see the doctor and confront them and say, I need this, I'm feeling this. From there all the way up to the legislative level, where you go up to doctors. I'm trying to educate them. I'm trying to make sure that we put in place in the system that no one can get through medical school, residency, and specialty training and come out and not have their biases challenged, not become aware of their implicit bias. When you were talking a little while ago, Maimah, and you said that you all were seeing this lady and weren't even aware that she was homeless. There's this image of Black women that we're not about anything. I don't know how in the world that could have developed even, but most of the time, Black women are handled so much, and they have too much pride, I should say to come in and tell you, yeah, I need help with my breast cancer, but I also am struggling in these ways, because we think we have to make it. That's what we've done.
But I agree, but I think too that for Black women, sometimes when you ask for help, you could lose your kids, right? The it doesn't protect us. So, she could have gotten the help she needed, but if she told the wrong person, she did who she wouldn't she should if she put her trust in the wrong person, she'd lost her kids, right? So
Yeah.
as a mother, what do you choose first? You choose your family first. And she's together. She's a smart woman. She's been through school. She is a strong badass. She's got things together. She's had some
Mhm.
things happen and gotten to a place where she couldn't figure out what to do. But then if I asked for the wrong group for help, I could get reported and lose my child and lose everything that matters to me. So I think sometimes it's a hard thing. The system is set up sometimes where we just can't get the support we need. But to Jamil's point and to your point, if there were some policies in place, which there have to be, that's my goal for next year. Going into the future, we have to ensure there's legislative like policy, like laws in place that will assess teaching schools, that will ensure more Black people are going into STEM careers, that will
Mhm.
expose and track the quotas in high school of exposing young girls and boys to science and math and technology programs, that will give these big centers money or hold money back if they don't get the right things in place. So that way, if we teach students, providers, educate patients, have these angel programs, do equity assessments, people like yourself, if every stakeholder is touched by this, in
Mhm.
some way, and they're accountable and we're
Mhm.
measuring specific, time bound goals, that's how we get to the nirvana I think we want to all achieve in our lifetime.
Yeah.
And
Yeah.
to be honest, it goes back to just really giving people the basic human right and privilege to live that life if they are afforded all the right, people in their lives to support them in the healthcare system, the right tools. If they get protected by the systems meant to help them, they will be able to get through their lives and get that support. But it has to be that we set time bound goals. If they could find the COVID-19 vaccines, but it was like two in like 6 months
Mhm.
and more. Now, how could if we can put that level of focus into, helping to try to stop COVID, so laser focus, we have to apply that same lens to ending disparities and
Mhm.
making making it a time bound goal.
And I think too, sometimes I think the healthcare system needs to be turned upside down. Jamil, you said this earlier, and it's true. At the primary care level, we're the ones who are on the front line, seeing people, have the trust of people. But the way the healthcare system is set up, monetarily, you have to try to see a certain number of patients to make a living. That's why I had to
Right.
step outside of that system. I cannot do that. I cannot shortchange my patients so that I can make a living. What helps me to do that is the clinical trial things and the other things I do. I don't make a living from my practice, but we need to turn that system upside down so that primary care people have the time to spend with patients, and by the
Mhm.
time they're up to that neuro oncologist or whatever, even the breast oncologist, they're working so hard to be able to get patients that they're going to spend whatever time they need, because they need to financially be able to get patients in order to make a living. Right now, it's like they can be kind of lackadaisical about it because all the money's flowing upward.
Yeah.
And I think that system has to be challenged too, just financially.
Oh
It's
yeah,
hard.
so we try to disrupt our way into it, and we're working with
Yeah,
health
yeah.
systems. I can just think of one cancer center where their oncologist patient visit was 10 minutes.
Whoa.
10 minutes. And so when you think about the wait times and billing and insurance
Hmm.
issues, all those things are just additional barriers layered on top of what it is just to get to that next step in order to get that care. And I'm really
Hmm.
proud of the work that we've done when it comes to coaching connection to patients
Yeah.
and the impact on clinical trial enrollment and retention, because clinical trials, it is just, if you're living with metastatic breast cancer and you're trying to navigate this whole system and what documentation I need and who to submit it to, it's a whole nother conversation to make clinical trials more patient centric. But the
Right.
fact that if that system isn't in place, where again, we know that we can deal with getting it on the radar of people that don't understand that they have a higher risk of breast cancer,
Hmm.
encouraging more students to learn about bias and implicit and explicit bias and how that manifests in the care system, and for more Black people and brown people to pursue these careers, and then for patients to have that reinforcement so that they don't have to fall through the cracks. And then also that accountability measure when it comes to the health system. So I think that's where all these different touch points, when we think about the continuum, that's how we're going to see these, barriers addressed when it comes to these solutions.
But Dr. Phillips made a big, important statement too, not but and, because if you're not getting the time with your patients that you want, and you're doing your job, which is to be a heart-based physician, what are you going to do? You're going to go to a hospital that maybe is bigger, that will pay you more money, or you may go into your own practice, which means that the community centers that need patients like Dr. Phillips will not have physicians like her. So, it's a kind of a no-win. So how do we ensure people stay where they want to be and don't get penalized for talking to a patient more longer, or sitting with a patient and answering those questions? Like when I was diagnosed, the first doctor, she's the one I fired. The next one said, "You just said cut him off," like that. And I'm like, "What?" But the third physician, she sat down, pulled her chair next to me, we're knee to knee. She put out her hands and she said, "I got you." And she spent probably an hour with me. I was stunned but she had to leave she left to go into her own practice so she could have time with her patients. So how do we make sure that people are afforded the opportunity to be in their communities that are facing these disparities, that need people that look like you, that have the heart that you have, where they can stay there and give them that one-on-one, patient-centric, culturally appropriately, in time care? That has to be part of how we get the system change as well, Jamil.
And if they don't, pull in community-based organizations like ours, or pull in those oncology social workers or nurse navigators or practitioners that are trained. Because some people, they have bias. You can work through that. There are exercises and trainings that you can do to kind of check yourself a lot of times. So when you have that knee-jerk reaction to not provide that test, or not connect that Black woman to that clinical trial, or to push back on that resource, or to say that her pain is not valid, or she's not entitled to that palliative care. Think about that knee-jerk reaction. Would you have that same reaction if this was your sister or your mother or your aunt, or a white woman presented in front of you? What is that block that is prohibiting you from stepping forward to provide that patient with the support that she needs?
Jamil, I think with what you said, finding those resources, finding those social support resources, that the navigator, the social worker, the coordinator, those are all important, especially to take care of that total patient and help them through the breast care continuum from diagnosis to survivorship. As we come to an end, I want to extend the last question, which is so important. Both of you shared throughout this whole dialogue work that you're doing with your respective organizations. But can you specifically, and as we close out, tell us about the work that your groups have done to uncover these issues and to intervene at the level of patients and clinicians to address these inequities? And if you want to share what's to come.
Jamil?
You want me to go first?
Yeah.
So I'm so excited about, the fact that we have the Chrysalis Care Tracker and the Chrysalis Coaching Program. And it really, no matter if it's pre-diagnosis, diagnosis, treatment, living with MBC, that full continuum, we're making sure, because we know what quality standard of care is. We know what comprehensive cancer care is, making sure that those gaps are being filled so that no matter where they live in the country, that they're able to get the support that they need. So we're going to, that's the one wraparound Chrysalis support, for patients. And then for cancer centers, guess what? We're revealing those blind spots with our equity assessment. So you think you got it going on. You are, you have this great care delivery and cancer program at your cancer center, but are your Black and brown patients receiving that same standard of care? Is that questionable? Are you still suffering despite the town hall, despite the implicit bias training, despite, having it in your mission statements to deal with inequities? Are you still, despite your Black and brown patients having access to care and having insurance coverage and filling in those social determinants of health gaps, is this still a persistent problem? Why is that? Are there maybe blind spots and silos within your cancer center that are not being addressed, where that accountability is lacking, and it's resulting in substandard care of those patients, and that impact. Work with us in order to address and hone in on where those blind spots are, and then how we can work together in order to provide the care to these patients that they need. And then we have BC Navi, which is a resource behind the scenes with all the data in order for us to really hone in and know what are the barriers and challenges that patients are reporting as far as their outcomes, making sure that they're adhering to their treatment, identifying preemptively wherever they fall below baseline as far as that care continuum, and working with the cancer center teams in order to make sure that we can flag you. It doesn't always have to be the squeaky wheel. It doesn't have to be the patients like Jamil and Maimah that, are going to, hey, I need this, that, and the third. But you can have someone advocate for you, or, a lot of Black women just muddle through. They don't know that, no, that's not normal. This is where the standard that you should be. And this is the level of care that you should be receiving. And this is how continue. Cancer is a long-term thing. So whether you're early stage or metastatic, this is with you. You are going to have to sustain yourself to keep moving forward. And this is the support that you can get in order to do that. And so behind the scenes, with patient-reported outcomes, with cancer centers understanding specifically what are the blind spots and things that you need to address at your center, and making sure that we equalize across the board.
I love it. Thank you.
Yeah.
Maimah.
How much time do I have?
There's never enough time, is it?
So I think for me, the first thing with Tigerlily, I wanted to be a place where people go to the site, they breathe. This whole journey, when you get diagnosed, your whole life just, as you know it before, stops. And you're like, oh my God, they're telling you they literally hear a person talking about your life, and it's like, okay, you got to be a cancer expert in the next week or two. And it's not possible. And you're so stressed. And so I thought, what did I need the most? I needed comfort. I needed to feel a place where I could just go, I'm okay here, And so, we create an atmosphere that is totally heart-based, first of all. And we want to apply that heart-based intervention to all that we do within health disparities. We teach young women to come to us and be empowered and go back and take that commitment to God, to their communities, their sisters and mothers and daughters, back to the community, and do what we're doing on a national level in a community setting. We work with providers to educate them as well. We launched our inclusion pledge, which was a beautiful surprise of how it blew up, because we began working with pharma and advocacy and saying, take the inclusion pledge and work with an organization that's a Black patient-led organization that's been through, that can tell you what you're doing right and are wrong, and let me help you help my people, and help everybody else. How do I help you do that? You have not lived my experiences. So we launched a pledge, in 2019, and we now have 15,000 signatures across the country, the world actually. And people are taking the pledge in healthcare systems, in policy making arenas, in community centers, but they're taking the pledge and they're assessing their biases, privileges, or their lack of that lens of asking why not. And so we're seeing these huge organizations really change. We've seen pharma make commitments and run these huge patient-centric sessions that I am part of, that I'm like, oh my God, look at what's happening. Just because he took the pledge and I said, can you please do these 5 things this year? And it became 10 things, and other people got involved, and it got bigger and bigger and bigger. It now affects not just breast, but cancer across the board. I also love the work we're doing with our advocates, because we're having them to challenge the system, ask why not. Don't accept the status quo. So we want to force multiply, and we've trained so many Black women this year. It's so wonderful to see that the angels are all over the place. They're flying and soaring. We also do a lot of work in the policy arena, so affecting policy change. When you change policy and people's pockets are accountable, a lot can change really fast. So that's happening as well. We also launched our Breathe TV series, which I love. Ashley was on Breathe talking about her mom, who got her wings many years ago. But people can come to the series and just talk about breast cancer, grief, death, life, all of that, all the health disparities. So we're doing so much around so many different things, but our clinical trial work's been really important. We've been working with CROs, with healthcare systems, with AI systems, with pharma, to help advise them how to best be inclusive and diverse in their trials in a way that's human and patient-centric. And through that, we have, God, probably like close to 40 or more partners that we've are working with to help them make everything from the research phase to the informed consent forms to their data on the website to their even how the trial is coming out. So it's been a year of a lot going on, but I think that, as Ashley said before, and Dr. Phillips and Jamil, like this is all like God work, right? And so I think when we all do our part, the Bible says there's one body and each body has a part. So that if the ear does its part right, and then the eyes doing that part right, and the mouth is speaking the truth right to power, then we
Yeah.
all become this beautiful collective that makes this huge goal of getting health equity possible in our lifetimes.
Well, thank you so much, everyone, for joining this panel and making that. I hope that everybody took all this knowledge and these solutions and feel empowered to go on in 2022 in order for us to continue to make a difference in all the work that we're doing. So
Yes.
shout out to all the advocates. Let's continue to push forward and definitely connect with all the organizations that were highlighted on this panel. Thank you.
Thank you all for your time. This
Thank
is wonderful.
And thank you, Ashley.
This
Thank
was
you,
great,
Dr.
great.
Thank you,
Dr.
Maimah.
Phillips and Jamil, thanks.
Thank
Awesome.
you all. Thank you.
Yeah, this was wonderful. Glad to be a part of it.
Awesome.